Okej, jag lämnar över till dig.
Hej, Luke Sheehan heter jag, familjebehandlare i Bromma här i Stockholm. And now, I go to English. Now we have the pleasure of going to listen to Peter Robert. Peter's a practicing family therapist. He's a researcher and teacher. He's professor of clinical psychology at the University of Louvain's Institute for Family and Sexuality Studies in Belgium. Within the institute, Peter is coordinator for Context, a center for marital and family therapy. And my colleagues and I visited Peter at Context in Belgium, and we were very impressed of how family therapy was being practiced and researched and taught all under the same roof. We were in Louvain to learn more about the dialogical feedback model that Peter and his colleague Karina developed. The family counselling team from Bromma, of which I'm a part, will be presenting a workshop on that, how we use that model after lunch. Peter has also published very widely in the area of family therapy. And for example, this book here, In Therapy Together, Family Therapy as a Dialogue, I can recommend very much. Peter has also been a long-term active member of dialogical practice, participating in publication and conferences. So please now give Peter a warm welcome to Stockholm.
Thank you. Thank you. Thank you for inviting me. It's really an honor for me to be able to speak here for so many people. As Luke told, I'm a professor in psychology at the Leuven University, so it means that I do quite a lot of research, I do a lot of teaching, and I also practice family therapy especially. And today I would like to speak about the complexity of the alliance, because doing family therapy, I think, is very complex, and sometimes I wonder why I ever chose this profession. In another meaning, it could be that this profession chose me. In fact, I didn't want to become I wanted to become a psychologist, but I didn't want to become a family therapist. But in some way, I ended up being a family therapist, and sometimes it feels like the right choice. Sometimes I think I should have done something different. But most of the time I like my job. And so I'm going to talk today about also about some of the times that I wonder, why do I do this? One of the most difficult things being a therapist, being a family therapist, but also being a therapist, is that when we meet people who are suffering, we get mobilized to help them. And what we can do to help them is always falls short. It's not enough. There will be always more suffering there than I can help. And sometimes this is very heavy to bear. Especially, I'm a child psychologist, especially when working with children. For me, working with children, seeing them suffer, and not being able to help them, it really keeps me awake at night sometimes. And the alliance, making an alliance in families, usually also means making an alliance with children, which is also a very special challenge. But I will talk about that during my talk. I'm going to talk 2 hours. That's quite long. Not for me, I can talk for 2 days, but for you. So I hope I will keep most of you awake. I hope some of them in the back rows can fall asleep because maybe they need it, but I hope most of you will stay awake. We have a break at 11 o'clock. Anyway, I would like to start with 2 cases to illustrate the complexity of the alliance. The first case, it's a therapy I did 6 years ago or something long ago. And it still is a very special therapy for me. And it's about Annie, and Annie was a 21-year-old young woman, and she had been diagnosed with all kinds of diagnoses, but the most recent diagnosis she had was bipolar disorder. And her mother phoned me, and she said, "We want to come because we want to talk with the whole family about Annie." So I invited them, and they came, but Annie was not there. Who was there? Mother was there, stepfather was there, and the brother was there, but Annie didn't want to come. They told me the story of Annie, and they said that she had a lot of hospitalizations in psychiatry. She had done several suicidal attempts. She was on heavy medication, but sometimes she didn't want to take it, and so on and so on. It was a very, very long story of how this mother and the stepfather and the brother tried to help Annie, but it was no use. It really didn't go well with her. And in fact, every day again, they wondered, how is it going to be today with Annie? And the more I listened to their story, the smaller I became. And the more I started to think, how can I help these people? And then they started to say about the long road they've been through in psychiatry and name all the psychiatrists and therapists they have been to, all the big names in Belgium. I thought, what am I going to add to that? Huh? So by the end of the session, I felt really small, and I said, I'm not sure if I can help you. The long way you've been on, what can I add to that? I can see you love her, I can see you did everything to help her, but I feel powerless now. And maybe we can make another appointment next week or in 2 weeks to talk about powerlessness, but that's the only thing I feel right now that I can talk about. They went home. I felt like a very bad therapist. I had the feeling that maybe I should have become a farmer or a car mechanic or whatever, but not a therapist. And I felt so bad and shitty, and I thought about how unjust life is, because I have a son and he's healthy and he never was in psychiatry, and so on and so on. So I felt also this imbalance in an ethical sense. And then the next day I got this email. And this email reassured me, but at the same time it made me think about what is therapy all about. For one thing, this is what she wrote: we're nowhere near a solution. While a lot of people have the idea that therapy is about finding solutions, this mother says, this was a good session for me and we are nowhere nearer to a solution. Also, it was in a sense strange that she said we felt understood rather than blamed. We felt understood. That's something to think about. Because I felt that I understood the powerlessness and the love, but I didn't understand the problem. I didn't understand why in this family this young woman had to suffer so much, and how come that these people didn't find a solution for her. But it seemed that she also said something else. We were not blamed. And then you have the idea that if we think too much or try to understand too much the causes of the problem and about solutions of the problems, that sometimes it feels to some people like blame. That's something to think about. I've seen this family one more time, and then we talked about powerlessness. And after that, Jenny said to me, this is enough. But we kept in contact. She kept sending me emails talking about how Annie was evolving. And Annie did very good. She got out of psychiatry, didn't do any suicidal attempts anymore, is married now. And the last mail I got from Jenny was to ask me to vote for Annie in a contest of DJs. So it was on a website with different DJs, and you had YouTube films, clips, and you could vote on the best one. And she wanted me to vote for Annie. For me, it's also interesting because if you would ask Jenny, the mother, if you would ask, how can we understand that things changed for Annie, she would say that first session with Peter. I don't believe this, but that's what she would say. The session when I felt powerless. That's her story. In one of the emails, she also sent me this sentence, not the elephants. The elephants I added myself, but the sentence. And she said, "This is what I learned in that session." For me, this is an important sentence, and I used it when some years ago I was asked in the United States to do a keynote address at a conference, and they asked all the speakers to make one slide in which they would point out the most essential thing in family therapy. And at first I thought this is an impossible task. But then I thought of Jenny's words, and then I made this slide. For me, this is very important. And this is not a technique, this is not an intervention, this is not a diagnosis and so on. This is some kind of attitude that we can adopt as therapists when we listen to families. And when I show this to my students in Leuven, always some of the students, they say, but most of the families we see, there is abuse and there is violence and there's sadness and so on. There's no love. And then I always answer, but the love, you have to believe in the love. They don't believe in it anymore. They don't feel it anymore. But you have to believe that this is a family that is founded on love. The foundations are love. Most of the families are. Most of the families in our culture, maybe in other cultures too, I don't know, but in our culture, most of the families started with love. There's a girl, there's a boy, they come together and they feel something for each other. And in the beginning, it's only for each other. But then after a while, there emerges a space for a third person, a child. And the child usually is born out of love. If I keep this in my heart when I listen to people, I can listen in another way. So it's not with my head trying to diagnose or trying to find solutions or trying to come up with hypotheses about what's going on, but I think I want to first connect with love and get some sense about what makes these parents or these children trying to make it right for each other. Well, I sound like a priest now, huh? But for me, this is important, huh? And it's not at all a denial that there is a lot of violence and a lot of abuse in families. I know if I would make a bet, and you would say there's a woman who has been murdered and who did it, the husband or some kind of stranger, I would bet on the husband. I know. But we have to keep this in our heart, I think. Let me talk about another case. It's a bit, it's not so nice to talk about cases, because these are people. The next family therapy case I want to talk about is also something special, in the sense that this was a therapy with Jenny. It was not really Jenny. You'll see that I often use the word Jenny, but it's just Jenny was 15, I think, and she had an eating disorder. And I did the first session with the mother of Jenny and with Jenny. And then after this first session came rather long therapy. During this therapy, at a certain moment, the mother says, I keep a diary. So we talk about the diary, and she says, I even made an entry after the first session with you. And I was interested. I thought, can I read it, that entry about that first session that you made in your diary? And she gave it to me. And it was very interesting. And I used it to rewrite it and to make a story of it. So what I shall show you is a story I made, but it's based on the diary entry of that mother of that session. So maybe I can... I made a little film clip of it. I hope it works. I made it just yesterday, in fact, especially for today. So this is a premiere. But maybe it won't work, and then I will just read it out for you. Huh? I really tried very hard to understand what his mother had written in her diary, and I thought it was wonderful how this was the first time that I got such a perspective on a first session. And in fact, when I listened to it, and I made this story of it, but when I tried to listen to her, there were four parts in it. The first part was when she, in fact, was angry with me. I said to her, maybe family therapy is something for you, and she got angry, especially because she felt blamed. Because she said something like, is it my fault that she doesn't eat? I didn't blame her, I didn't say it was her fault, but when I proposed family therapy as a way to deal with her worries, she felt blamed. And another thing is that when I said, yes, but in family therapy we talk about worries or something in that thing, or something like that I said, and then she said, yes, we can talk at home too. And this is what people often say, we can talk at home too. And in fact they say, but we don't. We can, but we don't. For me, it's very important, that last sentence. Family therapy only makes sense that we can talk in a different way here. And that's my goal as a family therapist, to have a dialogue with families or with parts of families, and to do it in such a way that it adds something to what is already there. And this is, for me, it's in fact very important, because I don't aim too high. If you aim so high that you say, I want to solve your problem, that's especially, maybe not for all, but for the kinds of suffering that I see is quite intense. You can say that we in Leuven, we are some kind of an end-of-the-line center. So when they have been there and there and there and nothing worked, then they come to us. So it's not always the most easy difficulties that we get confronted with. But for me, I try to aim not too high and to aim just on this idea, let's have a conversation with each other that you didn't have yet. And when I talk later about feedback instruments, that's one of the things I want feedback about. What's new? What has moved you, what has touched you as a person, but also what has surprised you, what was new. So these are very important questions for me. So that's the first part. I am confronted with her anger, and I have to deal with it. Did you notice how often she used the word calm? It seemed, I didn't know it beforehand, but for her it was very important that I remained calm. And she says it with this kind of surprise, as if she's not used to that, as if when she's angry, the other becomes angry too, but I remained calm. And that was important for her. The second part of the session started when she was angry with me, and then she looked at Jenny. And then she looked her in the eye and she saw hope, whatever that means, I don't know. But she saw hope. And that made a difference for her. And then she could feel, this is my daughter, I love her. And that made it possible to go to the next step. And then she asked me, do you think family therapy might help us? And then I said yes, and there's no guarantees. And then she asked about the husband. And then there's, in fact, a new chapter. In the first chapter, she kept focus on me, and the anger to me. Second chapter, she was focused on her daughter. And now, in fact, she's focused on her husband. And it is as if she starts to talk with me about the husband. And then, in the last part, she starts to talk in her inner conversation with her husband, thinking he will not want to come. He's so busy, he works so hard, he doesn't want to make time for us. And then also feeling, it would mean a lot for me if he would come. It would mean a lot to me if he would listen. I would love him so much more. Very interesting about this session is also that at the end of the session I said, okay, let's do a family session in 2 weeks, or I don't know how long was the next session. And I said, are you going to invite your husband? And she was going to invite him, but he will not come. But she asked him, and he said, of course I will come. It was, for him, it was so clear, and she was surprised. We had a second session. We had a third session. In the third session, he started to cry. And he said, at last I can have a part in the family, because so often I feel confined to being the earner and the breadwinner and so on. At last I can be a father. I often feel excluded as a father and so on. The mother and Jenny were very surprised by the tears of the father. By now the therapy is finished, and that's for some other time, but the mothers also sent to me the diary entry of the last session, which is also very nice to look at, but I didn't prepare it for today. But one of the interesting things about that was also surprising for me, that before the therapy, there had been several different therapies, but she was very suicidal. And the parents were very much afraid that she would commit suicide. And the therapist didn't help, didn't reassure them. There's one thing that reassured them, that's the horse. Jenny had a horse, and she didn't talk to anybody anymore. Not in school, not at home, not at the breakfast table, nowhere except with the horse. And every day she went to the horse, she caressed the horse, she cleaned the horse, she gave the food to the horse, and so on and so on, and she talked to the horse. And for the parents, they said that was the thread that we held on to in that difficult period. And then they came to me, and then you feel it already here, that Jenny, although she doesn't talk, becomes much more interested, and much more, you feel much more the link with the mother. That started there. Anyway, for me, this is interesting. Why is this interesting? Because I got very rich feedback from clients. And this helps me to understand some of the complexity of this alliance. If you look at this session without this feedback, you have the feeling that you had to convince the mother. But you don't know what exactly she's trying to process. I didn't know that she was talking in herself about her husband when I was in the session. So these are also for me 2 examples of how important feedback is to really understand what's going on. And of course, such rich feedback you don't get very often. But it reminds me of how important it is to try to get some kind of a culture in the relationship with your clients in which they feel more invited to really give feedback, and also critical feedback, which is the most difficult thing for clients to do, that is to give criticism to their therapist. Okay, let's talk very briefly about research. Outcome research shows that psychotherapy works. It doesn't work very well, but it works. The fact that it doesn't work very well is reassuring people. It means that when you have a week, when you have 10 clients, and 7 of these clients had the feeling that the session was good, and 3 of the clients had the feeling that the session didn't matter at all, didn't mean anything for them, then you had a good week. I know we as therapists, we aim high, we want 10 good sessions, but 10 good sessions, that's too high. Research shows that we cannot have 10 good sessions. 7 sessions in which we make a little bit of a difference. 3 sessions in which we do nothing. We mean nothing, we do nothing good. People go home and said, we could have gone to the park or to the restaurant, it would have been better than going to the therapist. 3 in 10. This should be reassuring. And this is something that, in fact, we all have to talk to our policymakers and managers about, because they want us to perform each time with a good session. It's impossible. This effect size of 0.80, it's not very good. It's good, but it's not very good. But it's better than a lot of the medication that we use, for instance, paracetamol for headaches. It's not better. Most of the psychiatric medication is not better. Okay? So in this point 80, it's not very good, but it's quite good, and especially in comparison with a lot of the other stuff that we give patients. There's also the importance of the relative efficacy. It means that, but as you know, the dodo bird verdict, the psychoanalytic therapy and the behavioral therapy and systemic therapy, in terms of effectivity, it's about the same. There's a little differences, and the differences are mostly, they're not big, the differences, and if there are differences, mostly in the direction that behavioral therapy and systemic therapy is a bit better, but it's not a lot. Okay, so for all purposes, it's maybe best to say that they are equally effective. So about these things, there's not so much controversy. About this, there's a lot of controversy. What works? What exactly makes therapy work? It works, we know it works, not very well, but it works. But how come that it works? And then you get a lot of discussions about, well, it's the model and it's the technique, no, it's the relationship and so on. I find this model with the 4 factors the most useful model. We need a client with a context. We need a therapist who has a relationship with the client. We need some kind of model or techniques, and we need this sense of hope. And then you can have therapy. If you lose one of these things, it won't work. It's when you talk to a behavioral therapist, very often they overemphasize the importance of the techniques and the model. When you talk to a psychoanalytic therapist, very often they overemphasize the alliance. I think you can compare it with a car. If you look at a car, what's the most important? Is it the steering wheel? Is it the tires? Is it the engine? I don't know. We all need it. We need all these things in order for the car to ride. Okay? Here we are going to talk about alliance, and the alliance in essence is a kind of a partnership, and it has a more cognitive aspect. Yes?
When you say client and context, could you say a few words about what that means?
Right. It's probably the most important thing. And it means that I can talk a lot about this because this is very important. Clients who are suffering very hard, therapy doesn't work very well. Clients who suffer a little, therapy works very well. Okay? So therapy works better for those who need it less. And this is something that's often used against us, and as a kind of, well, therapy doesn't mean a thing because it only works for people who don't need it. But that's for all these things. Also paracetamol for headaches, when you have a little bit of a headache, it works better than when you have a big migraine. Okay? All medications, all interventions in medical interventions, they all work better with healthy patients and not with smokers or with people with chronic disease or whatever, okay? So it's the same for us. If we have somebody who is motivated, who is talented in all kinds of creativity, intelligence and so on, who has a good social context, and so on, these people we can help better than if we would work with refugees who are traumatized, who are from a different culture, who don't speak the language, and so on and so on. In our team, we work with refugees, and I know how difficult it is. Huh? But it's not because it's more difficult that we don't have to do it. And it's especially this group that I'm interested in the group who are very difficult. Huh? Because then I think we can really make a difference. It's not only about the client, it's also about the context. So it's very important to try to connect as much as possible with the context. And I think that also individual therapy is important, but I think we too easily go in the direction of individual treatment, individual diagnosis, individual treatment, and so on. I had, a few years ago, I had a therapy or a phone call from a young mother, and she said, yes, I've these panic attacks at night, and I have nightmares, and I want to talk about this, and it has to do with my daughter. She was just a baby, and the fear that she would die. So I invited her and her husband to talk about this, but she came alone. And I asked, why do you come alone? I invited you both. And she said, yes, I don't want to burden him with my worries. He doesn't know about my anxieties. He doesn't know about my nightmares. And she said, no, I don't want to burden him, and I wanted to come to the professional right away. She had the idea that this was the best road to take. And then she told a story. Her husband and she and her husband, they went to Spain on the beach with a small baby, and it was a small baby, 2 years old, I think. And they were reading on the beach, and the baby was playing in the sand. All of a sudden, she looked up from a book, and she saw that the little child was lying face down in a puddle of water, didn't move. So she called her husband, they ran, and it seemed that she was dead. She didn't move, she didn't breathe, and they panicked. And at that moment, another tourist came by, and she was a nurse at our hospital. Coincidence. She was a nurse on holiday, and she resuscitated the girl, the baby, the small child. So everything was fine. The heart started beating again. Everybody was relieved. They went back home, started to work again. But then the anxieties came, the nightmares came, and she didn't talk about this with her husband. So I said to her, why don't you bring your husband next time? Ask him to come. And so the husband came, they talked, one session, and it was finished. The husband was so relieved because he said, I know there's something wrong with you. There's something on your mind, but now I know what's on your mind. Okay? So I think it's very difficult if you... I think the therapy would have been very much longer if I would do a therapy with I don't know what kind of intervention on the anxiety of this woman, while just this conversation and the reassurance, I am not alone, also he is afraid, and also he was afraid, and so on, that meant so much to her. So that's one of the things I very often do. I try to connect as much as possible with the context, and I know it's not possible always. But when you propose it to people, the first thing you always get is hesitation. They say, it's not possible. No, he won't come. So you need to have some perseverance. Of course, when it really is not possible, you have to accept it. But you have to wait a little bit, not to accept too soon. It's important because we know that there is a lot of spontaneous remission. People who want in therapy, but they have to be on the waiting list, and maybe they're 3, 4, 5 months on the waiting list, and very often during these 3, 4, 5 months, the problem disappears. How come? Not through therapy. And so there must be something in the natural context of most of the people that is very healing. Not for everybody, but for a big group of patients it is. And if there's no waiting list and they come to you, then I think you have to tap into the natural resources and try to use them as in collaboration, work in collaboration with them, which is not always easy, but it's important, I think. Anyway, let's go to the alliance. The quality of the alliance is important, so it's important that it's a good alliance, especially the quality as is experienced by the clients. So if you find in research, you find a correlation between the estimation of the quality of the alliance and the outcome. But this correlation is bigger when you estimate the quality of the alliance based on the experience of the client. What we have to do is be flexible. There's a lot of research about, we know that there's a difference between in therapists. Some people are very good therapists, and some people are not very good therapists. Some people are bad therapists. What's this difference? The difference has to do with flexibility. Therapists who are good therapists are flexible and can work with very different kind of personalities, of diagnoses, of social context, and so on. And the bad therapist needs exactly this kind of, then it will fit, then it will work. But when it's a little bit different of what I'm effective with, then I'm not effective anymore. So the flexibility is very important. And this is something that, this flexibility we also need when we want to be responsive to the feedback of our clients. This is for me also very important. Therapy is something very special. It's a process. And when you say this, that's a cliche. Everybody will say, yes, 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 it's a process. But what does it mean? For me, it means that it's not something like a pill that you give to somebody. And this person takes it and it will work. It's not like there's a car and the motor doesn't start anymore, and you go to a mechanic and the mechanic opens the car and looks, oh, this is too old, and this has to be replaced, and he replaces it and the motor starts again. It's not like that. It's, for me, a very important difference is I know that Nora Bateson is coming tomorrow. Fantastic. I learned a lot about this thing from her father. And I remember very well that I never met him, of course, but I saw a lot of films and I read about him and so on, and his work. And he tells this story about the difference between the living world and the world of billiard balls and stones. And for me, this is a very important difference, because when you think that therapy is the administration of some kind of effective treatment, then you think that the client is a stone or a billiard ball. For me, the difference is best characterized by Bateson. He says, when you're walking down the street and there's a stone, and you walk towards the stone and you kick the stone, then the stone will move in that direction in function of how hard you kicked and the direction that you kicked. So the stone will fall there and rest. That's a stone. If you walk down the street, there's not a stone but a dog, and you kick the dog, then you don't know what's going to happen. Okay? It can be that the dog just remains sleeping, but that's not very, very obvious. But I think maybe he will bark, maybe he will bite, maybe he will run away. Maybe he will run away and come back and bite. You don't know. And that's for me the difference with therapy. You don't know what's going to happen. You try to do something useful, and then you wait what will happen. And then again you will try to do something useful, and then you wait again. The waiting is usually very short, because it doesn't feel like waiting. It feels like a continuous process. All the time you're doing things. You're listening, you're talking, and so on and so on. And the client does the same. And this process we call the process of responsive attunement. All the time, the client and me, we are in interaction with very small movements and words and so on. And while he's talking, I'm listening, but I'm also already talking my next sentence. And he's thinking and he's already responding to, because the first words of my sentence already get a response. We can, this model of responsive attunement, we can link it to, for instance, processes of attachment. And as you know, in attachment theory, responsivity of mothers or fathers is very important. Let me show you a clip from the research of Ed Tronick on, you know, Ed Tronick is the guy from the still phase experiments. And I show it now to show you what a process of responsive attunement can look like.
Dr. Edward Tronick of Harvard and Children's Hospital's Child Development Unit has devised a way to show how important this social connection is to babies and how much it affects them when the connection with a parent or caregiver is broken. First, Dr. Tronick places 6-month-old Mackenzie and her mother face to face.
Hi. Can I touch her?
He asks Mom to talk and play with her daughter the way she normally does.
Hi, sweetheart.
Obviously, their connection is strong.
Yes, there's my baby.
The baby is engaged, responsive, clearly emotionally content. Then, Dr. Tronick instructs the mother to disengage by making a still face. She stays there, but doesn't respond to her baby. Mackenzie is confused at first. She's not used to Mom acting like that. Mom turns back, but keeps the still face. Mackenzie expects her to re-engage, but when she doesn't, look how the baby reacts. Even at this young age, she tries to entice Mom to interact with her. She reaches out. She smiles. She flails her hands, all strategies for getting Mom's attention. When that doesn't work, she becomes fussy, emotionally agitated. And finally, she just gives up.
The meaning of the event is this emotion that the infant is experiencing in relationship to this breaking of the connection in relationship to the mother. And that's a fearful, frightening thing. And the infant will do a lot to try and overcome it. But when they fail with a sense of helplessness and a loss of control.
Dr. Tronick then asks Mom to re-engage.
What a good girl.
It takes a moment, but soon the world goes back to normal for Mackenzie.
Round, down,
This striking dynamic happens not just with parents, but with any close caregiver, and at any age, like with 2-year-old Michael and his mother. Mom puts on the still face, and Michael tries everything he can to re-establish connection. When he fails, he falls apart dramatically, just like the younger child. Children also have another reaction.
Mommy.
Watch when Quincy's mother disengages.
Mommy.
He becomes distraught,
Mommy.
then more and more insistent, and even physical. But when Mom re-engages, the connection is re-established.
You did it.
Yeah, I did it.
And Quincy goes back to being his normal, happy self.
Want to talk on the phone?
Children are resilient, and breaks in close connection happen all the time in everyday life.
What are you doing?
What usually then takes place in good relationships is this reconnection that we've seen.
And we know now, looking at the interaction, that there are only maybe 20-30% of the time is the interaction perfectly, quote unquote, perfectly in sync. The rest of the time is sort of, you're in sync, you're out of sync, you're getting back into sync. And that's really what I think is the key process, which is getting back into synchrony.
Dr. Tronick believes that the process of disconnect and reconnect is not only normal, but positive.
When you reconnect, one of the things that can happen, not always, but some of the time, is that you create something new. If you create something new, you grow. And babies are about growing.
It makes a lot of sense to look at the alliance as a process of attunement, as an attachment process in a sense. I think it's also very important that Tronick, when he talks about attachment, he says even in safe attachment, there's not always a good connection. Sometimes you lose connection and then you try to find connection again and you can reconnect. And this we know happens in therapy too. We don't always have a good connection with clients. And then we can find or search for ways to reconnect. And this is, I think, very important Because in this searching for reconnection, what's very important is the fact that you're oriented towards the other. And for clients, it's the same. Clients are not disappointed when they lose connection with you, but they are disappointed when they have the feeling that you stop searching and that you have a still face, that you lose flexibility. If they feel that you keep on searching to find this reconnection, then it's okay for them. And then if you have such an alliance in which both of you, the client and the therapist, are looking for this connection, then you will find it some of the time in such a way that it is healing. That's the basic idea. And before the break, I'm going to show you another clip in which you can see how such a process of responsive attunement happens between adults, two adult women. But this clip needs a little bit of an introduction. This is a clip from a Dutch filmmaker, Frank van Os, and it's about comfort girls. And comfort girls, it's a euphemism. In fact, what happened is during the Second World War, Indonesia, which was a colony from Holland, was conquered by the Japanese army. And the Japanese army invaded that country. A lot of soldiers were there, but all these soldiers were men. And you know how men are, they need sex. But there were no Japanese women. So what they did was they went to the small villages and they stole young girls from the villages and they brought them together in brothels. And they're young girls, 15, 16 years old, in brothels, and there they had to service the Japanese soldiers. The Japanese army still denies that it happens, and they say they are only comfort girls, like a kind of, I don't know, a air hostess or something. But this is a film made by a Dutch film crew. They went back to some of these villages, and they talked to these girls. Of course, now these girls are in their 70s or 80s. And they talked about what happened during the Second World War, how they were abducted and had to service the Japanese soldiers. I'm going to show you one interview. You see an old Indonesian lady and a Dutch anthropologist who does the interview. She speaks fluently Indonesian. There's a lot to say about it. It's a small, short clip, but there's a lot to say about it. But one of the things that why I want to show it is because of the very nice responsive attunement between these two women.
Wedi kenai. Pikiran njrone wedi. Iki wedi. Brebes. Kelingan ngomah ning.
Tapi mereka juga ini main suami istri.
Enggak.
Nggak ada yang mereka cari apa di situ tamunya?
Ya omong-omongan baru omong-omongan guyon. Gitu terus bubuk mangke terus kisah. Terus mangke mboten dangu kancane dugi.
Tapi yang mereka tidur di kamar Simba, di tempat tidur Simba, bersama Simba.
Sedaya ngalami. Mengke ndang kok dosa.
bosan.
bosan, jelek. Jelek. Urung dadi bojone, wis dadi bojone.
This is, I've seen it 15 times, but it always moves me. What's interesting about this is how she starts out with saying no, and now in some way, the story is told. They were not my husband, and they pretended to be. And then all the touching. And then all the touching. And sentences like, a lot of women have had the same experience. We women, a lot of women had the same experience. So if you are too inflexible and ask questions and want clear answers, this will not work. If you are flexible and you use your body and you use your whole person, then you might be able to get this kind of moments in your therapy. And what's very special about these moments is that although she didn't tell a lot of things, she felt understood in these things. And that's what we are after, in fact. Not that everything is told, but that as much as possible is understood, also the things that are not told. And I think then you have a good alliance. If you have a relationship with your clients in which you can have that kind of processes. It's time for coffee. No? It's not time for coffee, sorry.
Thank you. Vi kommer inte ha kaffepaus, för det har vi precis haft. Vi kommer ha 5 minuter bensträckare och det kommer ske någonting här. Så att vi får sitta kvar, men behöver man gå på toa får man gå på toa naturligtvis. Så jag lämnar över.
I think we agree that our clients are not stones or billiard balls. So I think when we have an alliance with our clients, it's more of the kind of the responsive attunement, the kind of process you have with an infant, with a baby, or with another human being, or with an animal. The people who work with dogs or horses, for instance, also in therapy, it's the same. It's a responsive attunement process. These processes, they are not states. A state is something that happens now, and it's now like this, and tomorrow it's also like this, like a stone. This is a process that changes through time, and all the time creates something that was not there a moment ago. These are complex things, in the sense, for instance, that it's not explicit knowing that's central, but more the implicit bodily knowing. It's my body that knows what to do before I understand what I'm doing. And I think as therapists we know this, because sometimes in therapy we talk to a client and we hear ourselves saying some things that surprise us. Or using words that we maybe haven't used in ages, and all of a sudden in this relationship with this client I use this word. So it's an implicit knowledge. It's not explicit. And afterwards I can make it more explicit, and I can say, I did this in therapy because that and that and that and that. You can compare it also with sports athletes, like tennis players, for instance. It's the body that says, you make this movement and you hit the ball in that direction. And afterwards I can say, yes, I saw that she was more standing to the right and that and so on. But at that moment it's your body that does it before you explicitly think about it. Another thing is this orientation towards each other. It's the constant orientation towards each other. I'm interested in you. I focus on you. And that's that's really a precondition, and if you don't have that, then probably the process will stop, like in the sulfase experiments. So it's not my intention to do this intervention or to do that intervention. No, it's my orientation to you that makes me say this or that and so on. At some level, unpredictable. I'm not sure how you are going to answer to the question I'm just asking, or what you are going to say when I paraphrase what I heard in this way. And it's certainly a process that I cannot control. The only thing I can do to control is a still face and to step out of the process. But when I'm into the process, it's something we do together. And I will play my part, you play your part, and we do it together. So the only thing I can do, if I really have control, I have to step out of it. And that's also what you see happening with therapists who aren't so flexible and who want to hold on things, that the process stops. And the client tries very hard to be a stone. Instead of control, you need trust. And trust is something that usually starts very small, and you build. You build and you build and you build. And the building of trust takes time. The destroying of the trust takes just a moment. Okay? Think of a relationship, the relationship you have with your partner through the years. It builds and it builds and it builds, but if there's an extramarital affair or something really destroying trust, in one moment it can be gone, and then it again takes years to build it. Okay? This is typical for the responsive attunement. You can show it in this way. It starts out very small, all kinds of small interaction towards each other, and something grows, like trust grows, or intimacy grows, or safety in the relationship grows, and so on. So this is the kind of process we're thinking about, and I cannot emphasize enough how special this is in comparison to the world of stones and billiard balls. In fact, we should change our whole language when we talk about this. There are really words that can be used in the world of the stones and the billiard balls that don't fit at all in the world of the responsive attunement. And it's not so clear for me yet. I know sometimes I feel myself saying things that I say, it doesn't fit. This word doesn't fit. And so I think we need time as a professional group also to develop this language that really fits these living processes. And I think Bateson helped us a lot already. And some other people also, John Schotter, for instance, helped me a lot to think in a way of human interactions as living processes. But I need to learn much more. Anyway, we are going to talk about, or I'm talking about the complexity of the alliance in family therapy. So the main process, let's say, is the responsive attunement processes. In individual therapy, it looks something like this. You have the therapist there to the right, here he is, and then you have the client, and between them there's the process of responsive interaction, responsive attunement. But both have another kind of attunement which is more vertical. I with my own experiences. All the time, and that you saw it in the film of the first session, where this mother implicitly talks with her husband. There is this whole process inside me that I share a little bit maybe, but there's a much more complex process inside me, and it's inside the client, and it's inside the therapist. And inside the client, it can be something like, let's say that I'm a woman who, as a child, has been abused. I never talked about this with anybody. And I grew up. I fell in love with my husband. We married, but sexuality is difficult. And sometimes when we are in bed and we start to make love, sometimes all of a sudden it stops for me because I have memories of the abuse from my childhood. And then it becomes difficult between me and my husband. And then I go to the therapist. And the first thing I say to the therapist is, it's sometimes in bed with my husband, it's sometimes very difficult. Because yes, I want to make love to him, but all of a sudden it stops. And I tell this story about how it is in bed with my husband to my therapist. And depending on how he reacts and responds to my story, I will tell more. If he doesn't respond in the right way for me, I will maybe pause and maybe wait and not say some things and so on. But if he responds in the right way, I will tell more and more and more. And maybe in one of the sessions, in the 10th or the 15th or the 20th session, I will say, in fact, I've been abused as a child. But that part, almost unspeakable, it's very difficult to say, and I need really this trust that has to build through the sessions in order to have this context in which I feel safe enough to talk for the first time about what happened in my childhood. And while I'm talking as a client, the therapist is listening, but the therapist is not only listening and focused on me, but also focused on the inside, in the therapist's inside. And he wonders what's going on, and how can I help this woman the best I can, and maybe I should do this, and maybe I should do that, or maybe I can ask this, and so on. So also there is this inner conversation as a second part of the process. This is individual therapy. This is couple therapy. You have the therapist on top, and you have the wife and the husband, or the wife and the wife, or the husband and husband. But you see that already this is much more complex, because you have much more process of responsive attunement and also inner processes. So if you take the same example I just gave, except that this is now couple therapy, I go with my husband to couple therapy to talk about our sexuality, and what's unspoken, I never talk to anybody about my childhood abuse. Maybe sometime I will talk about this. Depending not only of the responsivity of the therapist, but also of my husband. For instance, if my husband says, you're always looking for excuses, you're always looking for somebody to blame, that will make me silent and not talk about my father who abused me, because he will say that I will blame him for the sexual problems we have now. If instead he listens and he's empathic towards me, then maybe I will find the safety to tell this difficult story that I never talked about before. But you feel that this already is much more complex. And then if we go to family therapy, this is a family with one child, it becomes even more complex. I wanted to draw a family with 2 children, but I couldn't draw it. So this is, in terms of complexity, if I show this to you, I think you can understand. If I show this to my manager or to my politician, he doesn't understand. You just have to do therapy with these people. You just have to give therapy or do an intervention. So that's in terms of stones and billiard balls, but this is in terms of humans. In family therapy, there is a lot of complexity, and the complexity very often has to do with diversity. There's not one client, there are several clients. And you can say that this is a family for the first session. The Smurfs, I think you know, in the Smurfs there's no mother figure. There's one girl, but she's not a mother. And so if this is a family, let's say that the mother died or went away or whatever. And let's say that this boy is the oldest, maybe he's 18. He phoned me to tell me that he's worried about what happens in his family since the death of their mother, and that he thinks that family therapy might be a good idea. And then this is the family that comes to me. They are in my office. And I see the boy who made a phone call, and then the father is very proud of his family. And I think these 2 people, I can make contact with them, I can ask them what brings them to therapy. But then there is this toddler. How can I have an alliance with this toddler, if I have a responsive attunement process with this toddler, what would it look like? And then you have the girl. And this girl, she's in puberty. And she's not really focused on her inside, she's much more focused on her outside. And she wants to know what the effect is that she has on others. Do they see that I have new shoes? And so when you ask her, how do you experience the communication in the family? She will think that's a strange question because you didn't ask about the shoes. And then there's this boy. And some people will say, oh, ADHD. Well, maybe, yes. But what's interesting about this boy, that this boy will probably attract a lot of attention in the first session. Everybody has attention. For instance, his brother, the brother says, be quiet, be quiet. We're the therapist, you have to be quiet. So this guy will attract attention, also our attention. And one of the things that's difficult with this guy is that when I ask a question to this guy, he will respond immediately. He will not let the question sink in or think about it. He will give an immediate response. Probably halfway my question already is responding. Okay? So it will be very difficult for me to have this relational attunement with him. And then we have this guy on the bench. And this guy on the bench, that's the typical adolescent. I've been practicing family therapy for about 34 years. I never saw an adolescent who was eager to have a family therapy session. In all my career, I only had 2 times that a child or a young person asked for therapy. All the rest, it were the parents. And this is, if you have a family with an adolescent, this is typically the position or the way he cooperates. And the whole body says, I don't want to be here. But they made me come. And so that's also a challenge. How can I have this alliance with this boy? And this is just an example of some of the complexity of family therapy, and the alliance starts in the first session. So if you want to get the train on track, you will have to start there. One of the things that helps me is that I make some kind of a mental picture like this, that I try to imagine all the family members on the line going from I'm prepared to talk about the presenting problem, or I'm not prepared to talk about the presenting problem. And for instance, in the Smurf family that we just saw, you can expect that the oldest boy and the father are very much prepared to talk about the presenting problem, and that the Smurf on the bench doesn't want to talk. For whatever reason, doesn't want to talk. But when I have this in my head, this helps me. When I meet the family, this helps me immediately to think about how am I going to deal with this complex alliance in this family. I'm going to give an example. There was a family that was referred to me by the police. The father in the family had committed suicide a year before, and the family, which is the mother, the older daughter, and the youngest son, they were in a program of the police about bereavement and things. And after that program, after about a year, the police said, well, we were still worried about this family, we will send them to the therapist. So these people had to wait for several months on the waiting list, and then at a certain moment they were in the waiting room. And I go to the waiting room, and I say hello, and I shake the hands of the mother, and I shake the hands of the sister. And then there was this boy, and this boy, I wanted to shake hands with him, and he did like this. Yeah. So he showed me his 2 dinosaurs, and he threatened me with them. And I answered, whoa, they look dangerous. I better be careful. And his answer was, and he threatened again. And I said, keep them close with you. They are going to protect you and your family. And he said, again. And then mother said, okay, give the mister a hand. And he gave me a hand, and then we went to the consultation room. For me, this is very important, these dinosaurs. It were not these dinosaurs, but there were dinosaurs like this. These are very important, and they show me that's the boy on that side of the continuum. I don't want to be here. I'm not eager to be here. I don't want to be here. Afterwards, looking back at this scene in the waiting room, I'm rather pleased with how I reacted. Sometimes I'm not pleased at all, but this time I'm pleased. The difficulty is that you go into the waiting room and your intention is to shake hands and to say welcome and to bring the people to the waiting room, but then something happens and you're confronted with these dinosaurs. And what are you going to do then? And you don't have time to think. You have to react immediately. And I can think of some other things that I could have done to respond to these dinosaurs. But afterwards, in some way, I don't know why, I don't know how I could know, but in some way I gave a good reaction. How can I know? Well, I can know because of how the therapy went. And one of the things that I learned in the first session was that the father committed suicide, but he didn't die right away. He put a gun against his head and he shot himself, but he was in a coma. He wasn't dead right away. He stayed awake for about 2 weeks. And he was admitted in our hospital. So in the same hospital, in another wing, but in the same hospital as where the family therapy went on, was the father died. So I could understand why this boy wasn't eager to come to this hospital, because that was the place where he went to visit his father, and then his father died. No, there's another reason why I think that my response was not bad. I said, keep them close to you because they can protect you and your family. And later I learned that these dinosaurs were not something that he bought in a shop, but they were given to him by one of his teachers. And this teacher gave special attention to him because also in school he was not very open, didn't have a lot of friends, and so the teacher gave a lot of attention to him. And during some breaks and so on, the teacher invited him to come to the class to help in the class and so on. And at a certain moment, the teacher gave him 2 dinosaurs, and he said to him, "They will protect you." Just the same words as I had used. I didn't know. But then I knew that my being respectful for these dinosaurs and saying they will protect you meant something for this boy. And at the end of the first session, when we talked about these things, I said, yes, we can make a new appointment in 2 weeks or something. And would it be okay, mother? And she said yes, and daughter, and she said yes. And then I thought, yes, this boy, in fact, he didn't want to be here. And then I asked the boy, and he said, yes, I want to come back because it smells differently here. And that was his way of saying, I now can make a distinction between the hospital where my father died and this. And it's true, we are in a wing of psychiatry. It doesn't smell like medicine and whatever. And so for him, this was a difference. And in some way, in my intuitive responsiveness, I hit the right button. I don't know why. I don't know how I could have known. And sometimes you don't hit the right button. But you have to do something. Okay. Let's talk about this responsivity. So responsivity, the most important thing is that you do something. When there is an invitation of your client, there has to be a response. And that's one thing, for instance, in situation of waiting rooms, and I know that children usually don't want to talk, but when I go to the waiting room and there's a new family waiting, I'm focused on saying hello to the family, but I'm always also focused on what will the invitation of the child be. And of the smallest child, I'm much curious. And sometimes the invitation is, don't look at me. But sometimes the invitation is, play with me, or give me attention. So I go in the waiting room, I don't know what's going to happen, but I know there will be a child, and the child will be a challenge, the most difficult to have the alliance with, and there will be an invitation. And how can I be responsive to the invitation? And then I step into the waiting room, and I try to see what is the invitation. I try to do something that's okay. Yeah? And sometimes I do crazy things that afterwards I think, I hope that none of my students have seen me doing this. And it doesn't make any sense. Afterwards I can say I didn't make any sense. But at least the child had the feeling I was responded to. It wasn't really the connection that he was seeking, but I didn't neglect him. That's very important. When I start a therapy, for me there are also two things. There's one thing is the invitation, I invite people, and the second thing is my responses, my responsivity. So in fact, before anything is said, there has to be some invitation to be there. It's more than the invitation to talk, it's the invitation to be there as you are, who you are. And in that space that you create in that way, maybe things can be said. And then, when things are said, when words are spoken, but it's more than words, of course, it's especially also the body, when things are expressed, then there has to be responsivity. In whatever way, at best in a way that is really attuned, but it's not so easy always to attune. But that's what you try to do. And so there is some kind of receptivity. I accept whatever you bring to me, and that's some kind of a not knowing. But at the same time, there is a very active inner conversation, trying to understand what's going on here, trying to understand how I should be here as a person, what kind of Peter you need to come closer to who you are. And my responses, I hope, will open more space for dialogue, I hope. And for me, this is the most important thing. If there is more space to talk, also between the people, then I think I did a good job. It's not especially what has been talked about, but if the space is open, that's what I focus on. And so usually this process is a process of implicit knowing. It happens to me, to my body, when I talk to people. But at the same time, it's also something explicit. I also try to understand and maybe reorient. That I feel, whoa, I'm in the wrong way, I should do more like this, and then I change a little bit of direction. So at the same time, it's this implicit process, and at the same time, it's a more conscious, explicit process. And in that conscious, explicit aspect, feedback orientation can be very useful. And feedback orientation means that in a very explicit and systematic way, I will ask family members to give me feedback about how they experience the session. And that's what I want to talk about a little bit now. This process, this project on feedback orientation, in fact, is a project I did together with my colleague Karin van Tricht, but also with a colleague from Norway, Rolf Sundet. And we have worked on it for several years, and we have some ideas about how we as family therapists can deal with this feedback orientation. This is, I say explicitly as family therapist because being feedback oriented in family therapy, because of this diversity, think about the Smurfs, is much more complex than in individual therapy. And so it's about trying as best as possible in this implicit process to be attuned, and then moments of reflections in which you try to reorient the therapy, and then the feedback can be very useful. I will maybe. This is also important, the feedback. It's not only a question about which kind of instruments that you use, the SRS or something, but how can you create space in which the client feels invited to give feedback. And as we know, the most useful feedback is negative feedback. The most difficult feedback for clients to give is negative feedback. There is a lot of research on client experience in therapy. For instance, David Rennie from Canada did a big research on what clients experience. One of the things he found is that it's for clients very difficult to give criticism to the therapist. And what often happens is sometimes the client feels attuned, feels really supported, and feels okay in the therapy. And sometimes the client feels less okay in the therapy, and in fact he's not so pleased with the way it goes. And what usually happens is that the client doesn't talk about it, but starts to work more in the inner conversation and doesn't tell the therapist. And when that is not useful anymore, is not experienced as useful anymore, then he will break off the therapy and will not come back and will not notify you. And one of the things that we know from research is that when you work in a very systematic, feedback-oriented way, that, for instance, there will be less breaking, the clients will less break off the therapy. So the big challenge for us is the critical voice, but also as family therapists, the child's voice, but maybe also the voice of the psychiatric patients and so on. And what we found in the first years of family therapists trying to work in a feedback-oriented way is that they used instruments that were in fact instruments from individual therapy. And they used it in family therapy, and it worked a little bit, and it worked a little bit, no, not really, and so on. There was always this tension. One of the best and most researched instruments also in the field of marital and family therapy is the SRS of Scott Miller and Barry Duncan. But even that instrument, it's a good instrument, but even that instrument is not so, it's an individual instrument and it's not so useful in family therapy, I think. So what we did is we developed our own instruments, and these instruments, and that's where we got, that's where Rolf Sundet from Norway is so important. These instruments are not measuring instruments. They are what Rolf calls conversational tools. This means that these instruments cannot be used as outcome measurement. They can be used for in therapy, and they help usually that some things can be put on the agenda. Some things can be talked about because they have been mentioned in these instruments. But you cannot use it to, for instance, in a quantitative way. You cannot do statistics with it, and so on and so on. But still they're useful, I think. One of the first instruments I want to show you is the Worries questionnaire. And the Worries questionnaire is a questionnaire that we send to clients before the first session. So in our team, people do an online registration, and then we talk about the question in the team, and then one of the therapists takes the lead with his couple or with his family and so on. Let's say that I take the lead, then I send an email to this family and I invite them for a certain moment, Wednesday, and that time, and that's the address, and so on and so on. And I also send the Worries questionnaire, and I ask them, can you fill out this Worries questionnaire and send it back to me? Can you, all the family members, can you fill out the Worries questionnaire and send it back to me before the first session? I also say, in the first session we will talk about it. I also say, if there's somebody in your context, not in the family, but in your context, a teacher, a priest, a grandmother, whatever, and you think it's useful that she or he would fill out a worries questionnaire, you can do it too. Okay? This is what the worries questionnaire looks like. This is the first page. In the gray, what's mentioned in the gray area is a family therapist is someone who talks with families when someone in the family is worried about something. Before therapy starts, we want to ask you the following questions. So we define what a family therapist is. And this definition is very important. I'm not saying a family therapist is somebody who talks with families when there are problems. I'm not saying that a family therapist is somebody who talks with families when there is some kind of a disorder. Or I'm not saying the family therapist first does a diagnostic process to find out which DSM disorder we're talking about and that kind of thing. I'm not saying that. I'm saying we talk with families when somebody in the families is worried about something. And from the feedback we got from families, this formulation like that, for instance, for the Smurf on the bench is very important. Because the Smurf on the bench, when he reads this, when someone in the family is worried about something, he will say, my mother. There is no problem, but she is worried. So he will say yes to this. And the mother will also say yes. She will say, yes, I am worried. So this is a formulation of, or definition of family therapy that not always, but usually all family members can relate to. And then on the first page we ask who in the family is most worried. Who in the family is most worried? And then we ask to rate it on a scale from 0 to 10, and then we ask, can you tell us what this person is worried about and why this person thinks therapy might be useful. That's the first page. The second page is not the question who is most worried, but how worried are you? And of course, when this is filled out by the mother or the father, very often the person who is most worried, the mother, for instance, fills out this questionnaire and doesn't fill out the second page because it's the same thing. But I, as a Smurf on the bench, I can say my mother is most worried, and she's worried because I use drugs, and it's in all my friends use drugs. I do it too, but she doesn't need to be worried. And how worried am I? I'm not worried at all because it's normal to smoke joints, something like that. All family members are invited to fill this out, and when this is filled out, they send it back, and before the first session, I can have a look at it. Let me see, I got a case here. Yeah, then in the first session, what I do is first I make acquaintance with everybody, and it means usually that I talk to everybody not about the worries. I make clear, yes, worries we will talk about later, but first I want to get to know you a little bit, each of you, and I try to talk with them about something that's positive, that they think is positive. One of the questions, for instance, I often ask, what are you proud about? I first ask, who are you? Tell me something about you, and then very often I ask, what are you proud about? And that's a very surprising question for a lot of people, but I know why I ask this question. We know from research that very often, especially men, fathers, are ashamed to go to therapy. And I try to connect with it, something of the resources, something of the positive things. What are you proud about? Okay? And so that gives, in the beginning, I try to connect with more the strong aspects of the family system that comes to me, and then later we make room for the worries, and then we use the worries questionnaire for that. I will give you an example. A simple example of the worries questionnaire, this was a family that was referred by the family doctor, and the family doctor wrote an email and he said, well, it's about Eve, and I think, I don't know exactly how old she was, I think 14, 15, 16, I don't know. But Eva is developing an eating disorder, the family doctor wrote. I sent them all the worries questionnaire, they filled it out, and I put all the answers in a table. I'm not doing this always, I'm doing this for this presentation, so you have all the answers in one table. And here you see that when we look at the blue columns, which is the first page, who is most worried, that everybody agrees, mother, Eva, and sister, they all agree that mother is the most worried. And when you ask mother, what are you worried about? She says, Eva's eating, she hardly eats anything, it's as if she has anorexia. Eva says, mother is most worried and she's worried about me. Sister says, mother is most worried, she's worried about Eve. That's the first page. The second page, mother, of course, because she's the most worried, she didn't fill it out. But then the sister, Eva, she says, she does not trust me and she controls me all the time. She does not trust me and she controls me all the time. She is mother. And so you can say that what Eva says, she's, my mother is worried about my eating, but I'm worried about the relationship with my mother because she controls me all the time and she doesn't trust me. Okay? So you already have two worries. The worries about the eating of Eva, mother's worries, and Eva herself, I'm worried about the relationship with my mother. And then the sister says, we have to talk about mother because since our father left her, she seems depressed and I'm afraid that she drinks too much. So we have the worries about the eating of Eva. We have the worries of Eva of the relationship with her mother. But then we have the sister who's worried about the drinking of mother and of the depression of mother. And so when you start in this way in family therapy, you don't focus on the complaint or what the family doctor said or what the psychiatrist said. You try to have an idea of the landscape of worries in the family, and you try to talk with the family and connect with all these worries. It's not me that's going to choose, oh, this is the most important worry, we will talk about this. That's not what I do. I try to connect with the landscape. And concretely, usually, for instance, with Mother Eva and the sister, after making acquaintance with them, I put the worries questionnaires on the table and I ask them, is there something that strikes you as a family? And in this case, the case of the Sachs family, very soon in the first session they started to talk about father leaving, and they could very well connect it to the mother's worries about the eating of Eva, was connected with, in fact, she didn't feel okay as a mother, and so she focused on her daughter. Yeah. I give another example. This is the Tex family. They were referred to us by the psychiatrist of our own hospital. This was a psychiatrist who has a department of psychosis and schizophrenia, and usually the patients are hospitalized there for weeks or months, get a lot of medication. And for some reason, he sent this family to us for family therapy. The family, the boy, the 18-year-old son, was diagnosed with schizophrenia. There was a sister and a mother and a brother, a mother and a father. And this is the table with the worries questionnaires. I don't know what strikes you when you look at this. So remember, the blue columns, it's the first page, who's most worried and what's this person worried about. The green columns is the second page, what are you worried about? In this case, one of the most interesting things again came from the siblings. Both the sister and the brother referred to father and his obsessed by his son. And after we got to know each other a little bit in the second part of the first session, I put the questionnaires on the table, and father first denied us, you don't have to worry about me, there's nothing wrong with me. But then at a certain moment, the children were in their 20s, they're not small children, but they started to give examples. We came downstairs and we found you on the floor and you were passed out and you were drunk. And then the story came that the father was a banker, and was a manager in a big bank. But in 2008, because of the banking crisis, he lost his job. And he didn't find a new job, and he worked now as a taxi driver at night in Brussels. And he didn't feel okay at all. In fact, he wanted to commit suicide. But the one reason why he didn't commit suicide was that his son was schizophrenic. And he wanted, before he committed suicide, he wanted that his son would be okay. And when he told this story in the first session, then the son says, do you see? Nobody understands me. This is not about schizophrenia. I cannot become better because then my father will kill himself. Okay. So this also here you get this landscape of different worries, and you get some ideas. What are the things that are difficult to talk about? What are the things that are less difficult to talk about? This is just to give you a taste this afternoon. I think you will get more details about the use of these instruments. I'm going to give you one more instrument, not the dialogical feedback scale. That's for another time. Blah 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 blah. Dialogical feedback tool. Dialogical feedback tool is an instrument that that's filled out after every session in families when there are small children. Children, you can ask small children what age. Well, when children are not really comfortable with writing words, then we use this. And it looks like this. These two characters were present in the therapy session today. And then the question is, can you fill out the text balloons? And you have a smiling face and you have an unhappy face, and this one, the suggestion is this one is happy with the session, what's he happy about? This character is not happy with the session, what's this character thinking about? We have also another version with memes, which is for a bit older children, because they know these memes from the internet, but they can choose, of course. We use this in a family therapy with Emma, and this is also a very special case in the sense that Emma is the client. She was 8-year-old with behavioral problems like I never seen before. She's bright, she's creative, and she has serious behavioral problems. That's the worst combination that you can have. The first session, I went to the waiting room, and from the end of the hall, I could hear them in the waiting room. They were playing theater and so on. It was fantastic. This is the worries questionnaire. And in the worries questionnaire, you can see that everybody agrees that mother is the one who's most worried. Mother hopes that her husband is also worried, but she's worried. She's worried about tensions, about aggression, and so on. Father links the aggression with Emma, but look here, the brother says, "My dad, he can be very hot-tempered." Okay. And of course, Emma is the Smurf on the bench. I don't have a reason for therapy. Okay, we started therapy, first session. Get to know everybody. A lot of animation in the room, a lot of theater, a lot of movement, dancing, songs, and so on and so on. And we talked with them. And after the session, we got this as a feedback. This is the feedback from the first session of Emma. On the left side, she says it was not a good idea to come, and on the other side, it was a super idea. Of course, that's what we ask. We ask, give some, what's positive, what's negative, and this is her answer. But remember, she said, I don't have a reason. This is the brother. It was great, he says, now our family will be a group of friends again, thanks. A group of friends again. He wants to have a group. He doesn't want his sister to change. No, he wants to have a group of friends again. But then on the other side, it was a long session and it was never my turn. I hate waiting, he said. I was not at all conscious that he had been waiting. I had the feeling that we really talked to him and we really gave him the possibility to talk, but no, he hated waiting. And so when we saw this criticism, yes, we were pleased, because then you can immediately show in the next session that you're not hurt by this criticism, but that you listen to it and that you will try to use it in a constructive way. So in the next session, I said to him, I'm sorry that we kept you waiting. Is there anything about the previous session that you want to add to it? And I will try to really make sure that you don't wait today and that you will get enough room to talk. We can go to the next session, the feedback of the next session. This is what he says in the next session. Time went by very quickly. So in the first session he says, I hate waiting. In the second session he says, time went by very quickly, and he says this with the unhappy. This happens very often. When people are happy, then they say the session was too short, or I'm not so pleased that the session is finished yet, or something like that. So here we can see that in fact we succeeded in being responsive to his feedback in such a way that he felt understood. The second thing that he says is, it was a funny conversation and we are one step up, but we are not there yet. We are one step up, but we are not there yet. And I asked him, what do you mean? What do you mean with what we are one step up and not there yet? And then he said, he walked to the little table and he had made a drawing, and he showed me the drawing. He said, yes, you have to look at this. And he showed me this drawing. And he had drawn a house, and on the ground floor, it is the boosverdieping, the anger floor. Do I have a translation? I have a translation. The angry floor. And the second floor is the helpfulness floor. And the next floor is the friendly floor. And the highest floor is the nice, sweet floor. The liefverdieping, which is also the love the love floor. And he said, well, we are one step up. And he meant we're one floor up. And the whole therapy, he has used his house to tell us, to give us feedback about the therapy. Usually he said, yes, we're one floor up. But one time he said also, no, we're one floor down. And then, of course, then we can ask, Fred, what do you mean? What do you mean? And he said, yes, we're talking here all the time and everybody has good intentions, but then when we get home, they're angry again with each other. And then this gave an opportunity, open space to talk about, okay, how can we make sure that what you can do here as a family, talk together, be sweet to each other and so on, to make it like that at home too. And so that's the way that we use the feedback, also this kind of childlike feedback, in such a way that we can use it to orient, to give direction to the therapy, and it made therapy much more fun. Okay, I'm going to leave it with this. Thank you very much.
Thank you, Peter, for a really interesting session on how we can both build and maintain alliances. I think that everyone in the room shares the challenge we have in doing that. And this is just a small gesture from us. It's not a provocation to give you chocolate to a Belgian, but it's a present. So thank you very much.